With me is Siti Muga, and we do also have Dr. David Kariuki. He is the Chief Executive Officer of the Kenya Medical Practitioners and Dentists Council. Daktari, a very good morning to you and welcome to Radio Generation.
Good morning and thank you for inviting me this morning.
Right. Sometimes when we're having conversations here, we realize that sometimes people cannot differentiate between KMPDC and KMPDU. So perhaps for the council, maybe you can give us a little bit about your mandate before we get into the conversation.
Well, thank you very much. The Kenya Medical Practitioners and Dentists Council has been in existence from 1978. with a core mandate to protect the public from harm when they receive healthcare services, as well as guide the professionals, the doctors, dentists, oral health officers, as they provide services to our citizens.
Right.
Yes, the union is a welfare organization
for the workers.
For the workers.
Right.
Yes.
And in the recent weeks, we've actually seen a lot of activities coming from the council. For instance, the revocation of certain licenses. I also the the downgrading of certain facilities and so on and so forth. Maybe you can give us a little bit. Tell us perhaps why you saw it fit to either upgrade or downgrade. Certain institutions.
Right. Yeah. One of our core functions is as regulatory arm of the Ministry of Health or government in general to ensure that the public receives quality healthcare services. And quality has many aspects to it. And as we register and license health facilities to provide services to Kenyans, we also now do what we call compliance monitoring on whether the promise that facility that we registered is continuing to keep the promise as at the beginning. Sometimes you find they have not kept it, so you may give some sanctions.
Right.
Sanctions may be closure, revocation of a license. Some actually have done better than when we first registered them, and we actually upgrade. It's only that what gets to the news is more of the closures and the revocation of licenses.
Right.
So generally, that's what we do.
So how often do you carry out inspections to ensure that Hospital A, for example, has adhered to the regulations set out for them?
Right. We've set an annual check on every facility for compliance. However, maybe sometimes due to one challenge or the other, some may take up to 2 years. Considering that the country is vast, we currently have over 16,000 health facilities registered across the country. Sometimes you may find due to one challenge or the other, sometimes it could be weather, sometimes it could be resources, it could be lack of enough technical persons in terms of staffing that make us go for more than a year for a facility. Again, sometimes once we have inspected a facility and we think it is doing quite well, then we may actually allow it to operate for 2 years before the next compliance visit here.
Right.
So there are some we do even every 6 months because of the concerns we have on the kind of services they are providing. Remember, our work is not generally to close facilities, but to support them to ensure that they are providing quality care to the communities around them. Because the more facilities we have, the closer it is for people to get health care.
True.
So we balance all those things as we undertake the compliance inspections. Yes.
Are they usually random or are they scheduled? Like I know on the 1st of June, the KMPDC will be here to check out my facility.
Right. Most are actually random, but there are those that are scheduled. Random so that we get people in their real situations as they provide services. When we give them, scheduled visits, they will make sure that they are compliant at the time that we visit.
Yes.
Right.
Yes. We've had horror stories, and I'll call them horror stories because that's what they are, where a facility is registered at, let's say, as a level 3 or level 4, because it has the services that were said that they were being provided in that facility, only for you to visit them maybe a few months later and find out that maybe they had said they have maternity facilities, but on the day of inspection, it's like the machines they have been withdrawn and probably taken to GWare, or maybe on the day of inspection they had been rented. Is that the real situation on the ground?
Well, sometimes that may happen, and that is the reason we undertake these inspections to confirm that what somebody indicated they had at the beginning, they still have it and are providing the services.
Right.
Because again, even having the machines is one thing, but having the people to use them and provide services is also another thing. And you'll find, like, for a very new facility, most of the times they will have the necessary equipment, the infrastructure, but because they are beginning, they don't have the whole complement of health workers, which they keep filling up as time goes. And that's why we allow, like, a new facility to operate for about 6 months. So on the first day, they may not have all the workers, but we go back within 6 months to confirm that now they have all the workers. And that's how now the issues around downgrades and closures come in. Yes, because these are also based on the national standards. There is something we call the Kenya Essential Package for Health and the Kenya Health Policy, which are the guiding documents that we use especially to develop the standards for various categories and levels of health services in the country.
Can you walk us through this process that you've just mentioned?
Yes.
How it is you arrive at these standards, and what it is that is expected at the different levels, and how many levels actually exist, and the services that they actually provide.
Right. Yes, so thank you for that question. So generally in the country, we have 6 levels of healthcare service delivery. These were documents developed in the early 2000s by the Ministry of Health and came up with something called the Kenya Essential Package for Health. From this, we also have now the Kenya Health Policy. The current one is the Kenya Health Policy 2014 to 2030. The Health Act also defines, one of its schedules defines the levels of healthcare in the country. And each level defines the highest skill of services that is going to be provided at that level. So the Kenya Health Policy and the other documents I've mentioned define 6 levels of care in Kenya.
Okay.
The first level is the community level. That is the service you can even get at home. You know, basic, what do I do if I get
First aid
and all that. And this is where we have the persons currently being called community health promoters. The CHPs previously were called community health volunteers. We also have what we call community health extension workers. These are technical people in health, mostly would be either nurses, clinic officers, or what we call public health officers or technicians. Basically, they now oversee the services provided at home, make sure water, sanitation, and all that is well maintained, because that's where health starts. From there, we have the next referral is now the level 2, which are the dispensaries. These are actually now health facilities.
So, sorry, doctor, are you saying that my home is a level 1 hospital?
Yes.
Okay, carry on.
You're basically you're the first doctor for yourself.
Yes,
because it is you who starts feeling either there is something I'm not feeling well, there is pain here, there is no pain there. I'll take a good diet, my lifestyle, and all that. As you become the first doctor.
So
actually.
my home is a level 1 hospital.
It's a level 1 yes, facility. Right. So the level 2 now is a dispensary that you can walk to. Usually we say it should be the closest you can walk to. You may not need actually any form of transport, except those very sick will always need transport from home to the facility. So here in these facilities now, beyond what we do at home, the home remedies, now here there could even be a bit of medications, a bit of tests, like we can check your blood sugar, blood pressure, check urine, like that. And here, so the level here also, you'll have mostly nurses, clinic officers, you may have laboratory technicians, based on the services being provided at that level. So they could be many types. Again, you may find even at this level, you even have a dental clinic, is still a level 2 facility. You may find a physiotherapy clinic, is still providing very basic outpatient services. There are no inpatient services at that level. Yes. So beyond that, the next referral level is level 3, which is either a health center, and there are several types of level 3s. There are level 3s that provide outpatient services only, and there are level 3s that provide both outpatient and inpatient. Yes.
So for example, like at Kenyatta University, we had a health center. What would that be considered? A level 2?
Yes, it would be a level 2 if it has just a nurse and a clinic officer.
Yeah, that's where we used to go for general medication.
For basic
you have a cold, a sore throat.
That is where you go for minor ailments. Actually, we call them minor ailments.
All right.
Yes.
All right.
Yeah. So a level 3 is larger. So beyond just providing the consultation and minor ailments, it may provide a wider range of laboratory services. So those that might now even require pricking and you waiting for your result for an hour or two. You may have radiology, that is what we call the x-rays, what would be called x-rays, general radiology. Maybe you have a chest infection, they can check by an x-ray. Maybe you have a blood infection, they can check on the blood and the tests and such. You may have even what we call ultrasounds,
right?
For basic radiology diagnosis also. So at this level, in addition to the other staff we mentioned, the nurses, clinic officers, laboratory technicians, you may now have a doctor.
This is which level now?
Still level 3.
Oh, a lot happens at level 3.
Yes. Yeah.
Oh yes. Yeah. Is that the same place where we have minor surgeries?
That is
like circumcision.
So you'll have have minor surgery. So
stitching
this facility
of
will have what we call minor theaters, where one can have a minor procedure and go home on the same day. So here you'll also may have a dentist if it's a dental clinic. So we call them medical centers if they are providing outpatient services only. But then we could even have nursing homes, those that admit people for observation. We have some that provide what we call comprehensive maternity services. So those will have a maternity theater. Now this is a major operation. So they are still level 3,
yes,
but providing comprehensive maternity services. So they are even able to transfuse if there will be need for transfusion for a lady who is giving birth in that facility.
Because I've actually seen facilities that are even in their name, they are called XYZ maternity.
Yes.
So that's a level 3.
It's a level 3.
Okay.
Yes. And so for our daily administrative, we have given them level 3A, those that have both outpatient and inpatient maternity services. Then a level 3B is a medical center, like the medical centers you'd walk into in this area of town now. They provide only outpatient services, sometimes 12 hours or 24 hours. Then the level 3C are those that do not have theater services. So all these are still level 3.
All right.
So generally that is now all those that we have mentioned is what we call primary care services. Those services that you get from home, dispensary and health centers. Right. So now from there, as if illness is requiring more skilled services or more intensive care, we now have what we call primary hospitals, and these are called level 4.
So a level 4 is what is considered a primary.
It's a primary hospital. So it's the referral point for primary care. So those who have been managed at home, level 2 and level 3, and require referral, they are referred to a level 4. So it's called a primary care hospital that deals now with referrals that require, let's say, surgeries, may require admission for more days.
And by surgery here you mean like a major surgery?
Major surgeries, yes, major surgeries. Like you have to enter into the tummy, you need to operate maybe on the
chest.
eye, the chest and all that.
Can you give us an example of a level 4 that is of that nature here in Nairobi or even in Kenya?
Level 4 in Nairobi,
yes,
is like what you have Mutwini in Dagoretti. You have Langata. There is a Langata public hospital. There is also some private hospitals within Nairobi that are also level 4 in various areas, Imara, South Sea, and all that. There are very many.
Actually, Nairobi has very many.
Yes.
Okay.
Yeah. So those are level 4 facilities. Yes. You know, like even if you go like to Naivasha, the Naivasha District Hospital on the highway,
that's a level 4.
Okay. It's a level 4 facility.
So the level 4 facilities are the hospitals that at some point were sub-district hospitals.
Yes, what were called sub-district hospitals
or sub-county hospitals.
Current sub-county hospitals are actually level 4s. Okay. Yes, yeah.
Okay.
Right.
Level 5?
Level 5 now are called secondary hospitals. They provide what we call specialist services or specialized and subspecialist facilities. So they are called secondary hospitals. These ones now provide services beyond what we said is at level 4. At level 4, our requirement is that because it's a specialist referral hospital, you must have what we call primary level, specialists. So, for example, whereas in a level 3 you had a medical officer who will handle most of the deliveries, including those that may require cesarean section. In a level 4, there needs to be an obstetrician gynecologist to handle the more complicated deliveries and pregnancies, because it's not only deliveries, there are also pregnancies complicated by other maybe medical illnesses and such. So you require that skill of an obstetrician. There are surgeries that require that is above what a medical officer may do. So you require at least a general surgeon in a level 4, either in employment or on call whenever needed. Then you also need now a pediatrician that deals with illnesses of babies and children up to maybe teenage. And also now a physician who will deal now with illnesses like severe hypertension, other heart disease, other illnesses that are medical in nature. So in a level 5, now you will have surgeons, for example, who have gone beyond the general surgery. Some have gone, let's say, for example, into urology. So they deal with the prostate and all that. You may have gynecologists who have gone into cancers in women. So
are gynecological oncologists.
Yes, Now that's what a level 5 does. So it subspecializes. So you'll find in a level 5, whereas a level 2 probably has 2 theaters, a level 5 will have 5 upwards.
Give me an example of a level 5.
So currently, like in Nairobi, we have Mbagathi, we have South Sea Hospital. Those
Pumwani ina fall under what?
Pumwani would be a level 5, but Pumwani is a specialized hospital for maternity deliveries. And sometimes what we do is that for Pumwani, we actually give them a category we call level 4B. 4B is a facility that deals with only one specialty.
So if I go there with a sore throat, sitasaidika?
Utasaidika.
But sore throat unapeleka kwa clinic, brother.
No, but I just want to understand that that is the level of specialization
that is there. Yes, so you can find, like what we also hear, you hear cancer center. Those ones are also either a level 4B based on the specialists they have, or a level 5B based on the services they will provide.
Which level is Mama Lucy?
Mama Lucy is also level 5. We give it's a level 5 because it has all those specialities we have mentioned. Yes.
Okay. Let's move on now to these are level 6, right?
Now from there you have now what we call tertiary hospitals. So these tertiary hospitals now are the level 6. Beyond just treating, they are also largely used for training. So you'll find they have university hospitals attached to them, nursing schools attached to them. So they beyond that, and they also provide research. And they also have what we may call super specialists. So specialists who have gone beyond, like like if it were orthopedic surgeons, they have gone into bones. Now they have gone beyond and become, let's say, for example, hand surgeons. So they know
that one just deals with bones of
those who you
the
have
hand.
had in Kenyatta, reimplantation of limbs. Recently, I think yesterday or the day before, they were reconfiguring the face of a
patient.
child. Yes. And it's probably the first in Africa. So these are the level 6 facilities.
Right.
So you'll find even in terms of theaters, they have 10, 20.
Yeah. And I've heard even of specialists coming from abroad,
Yes.
coming to those specific hospitals.
Yes, so where we may have the facilities, but the actual skill has not fully developed. So the equipment are there. So normally we allow invitation of specialists from the rest of the world
to come here.
Yeah, it gets better for our patients because we would have had to take the patient to where the doctor is.
So, Daktari, from what I understand is that we are very well equipped, first of all, as a country and the facilities to handle almost anything.
Yes.
Right? But we are having a lot of people flying out of this country to go to places like India, the US, or the UK to seek that specialized treatment. Is it not easy to actually have some kind of organized plan, like let's say this coming month of October, where we are flying in a specialist in ABCD, so that those particular specialists can actually treat Kenyans here instead of a drove of us having to travel all the way to India or to the UK or to the US for these treatments? Because I understand the migration from here to India especially is quite huge on diseases and ailments, that we can actually have those people come here, sort it out, then fly out.
Right, yeah, you actually bring an important point, and I believe it's an issue around marketing of the services that we have in the country. And I am aware that there is currently development of medical tourism policy and strategy to attract now more people and reduce the outward movement of people to seek services that are easily or already available in the country, because we are developing our technologies more than previously.
Yes.
So we do have the outbound has been high, but surprisingly even inbound into Kenya, especially from within the East African region, is also very high.
We're talking about patients here.
Patients,
okay.
Yes.
So you're saying patients from other African countries also come to Kenya?
Yes, into both public and private facilities. Yes. I think the other day I read that about 5 years ago we used to have like 2,000-3,000 people coming in for treatment annually. Now we are talking of 10,000.
Wow.
Coming into all the facilities we have in the country, meaning that our healthcare system has grown and is becoming more trusted within the region.
Right.
And even some people come from outside of Africa, largely because of costs. They will come into our private facilities because it gets cheaper.
Right.
And that's the same perception with going to India. People believe it is cheaper. But I think not quite. From our experience, it's cheap when you are here and doing the calculation on paper. But if you follow most of them and get the final costs, there's a big difference.
Yeah.
And that happens even locally. When you get into a hospital, the issue might be that you're just going for this particular treatment. But while in there, maybe something else comes up.
Yes.
And now it has also to be managed. When you are here, it gets easy because sometimes some of it can even be done as an outpatient. But when you are out there,
you have to be in the facility.
If you do it as an outpatient, you'll still have to book a hotel from where,
or rent an Airbnb.
Yeah. Right. Yeah. So, yes. So, and we've been trying to, control this by asking that people confirm with us. We even have a medical referral abroad form that we ask people to fill in before they go, so that we confirm for them whether those services are already in country and whether they are accessible here. And we've managed to at least get some people to understand that maybe the service you'll get at the Kenyatta University Teaching and Referral Hospital for a service that was not there 2 years ago in Kenya and is currently available, it gets cheaper. And we've had some stories of where people have said, after we went there, it actually, the cost in India was going to be, let's say, 2.5. Here we ended up using 1.5 million.
Okay.
Yeah. And recently, I think the Cabinet Secretary has gazetted some services which they think are the ones that people should go out for, because currently we do not have the capacity to provide them.
Daktari, why do people really prefer going, especially to India? Let's focus on India for a minute. Why do people really like going to India? For example, my mom had cancer in 2021 and she got cured here in Kenya, thankfully. But I remember when we were seeking treatment and seeking second opinions, a lot of people who are not doctors kept on saying, si mwende India. Unajua India fulani fulani na akarudi na akapona na alikuanga na the same cancer. India is almost like they don't even need to advertise. People and Kenyans who've actually been there are advertising it for them. Why is it so?
As you've used the right word, advertising. I think there has been a lot of marketing, either by the facilities themselves from India and the local, referrals. I know I went there, I got well, you also went and got well. So one, the perception around costs, that it may be cheaper. Secondly, the time that I will go and get treated immediately.
Yes.
Whereas here you may be given a 3, 4, 6 month waiting period, and you see nobody wants to feel like they are waiting for 6 months, their disease is getting worse. Yet they are being told, if you come to us in a week, you'll have been treated. So I think those two are the main things: the perception around cost and the time, waiting time for the surgery, and the advancement in awareness creation. I think if we can do a bit more of awareness creation locally, that these services are available and the costs are also manageable, I think we'll be able to reverse that trend.
What of this whole issue of expertise? People also tend to believe that perhaps doctors in India, nurses in India are well trained, better, perhaps even equipped than those here in Kenya. Is that true?
Maybe you may say a bit of the technology in terms of maybe the equipment that they may have and some of those higher end facilities. But currently what we have here is also quite good. So in terms of expertise, in terms of the people, we have among the best.
Right. Yeah. So if we take a doctor here in Kenya, take them to India, they'll perform the same, if not better.
Yes.
Okay.
Right. Would you then there's been talk of one factor, the population that India has. When you have such a large population and we simply take an anecdotal view of the diseases that are likely to be prevalent, a person who's a doctor in such a country would have a much wider, should we say, opportunity to understand and to treat diseases than somebody who probably in an environment like ours. Would that statement have any truth to it?
Partly yes, it could be true, because even here locally, what we do, even when we are getting doctors into practice, what we call internship centers, they must have a certain basic level of service delivery in terms of workload. Because you'll find that medicine practice is more of a skill-based. So CBC for medicine is a lifelong thing. It started long ago. Because so the doctors, nurses are more about the skills they develop. Yes, there is a theory part of it in school or class, but then the skills that you develop, and you can only develop skills by seeing these things more often and dealing with them more often, so that even the dexterity in terms of hand and all that are more of a higher skill. So somebody who probably works at Kenyatta National Hospital that sees over 2,000-3,000 patients on a daily basis, and somebody who works in a facility that sees 10 to 15, they will have some difference over time. That even the instinct to even make a diagnosis just by looking and hearing, even without having to go to the lab, is higher. The index of suspicion in terms of having to get to a diagnosis and treatment would be faster. So I'm just agreeing that the higher the population that you have, that you need to provide services for, maybe the higher that the skills and such that are developed in a shorter time.
And we're saying this because if I look at, say, the what we're referring to, the level 5 public hospitals, and the population of individuals who actually go there, which also represent the diversity of ailments that take them there. So anybody who say is a doctor at emergency, that is a person who's going to see very many things that ordinarily somebody who was in that facility would not see.
That's true.
Yes.
Yeah.
In terms of rogue practitioners, we've seen some time back people were, for example, a very good example is Dr. Mugo Wairimo. I don't know, is he a doctor? Was he a medical officer? He was just a doctor who was an element that was like, what was that situation?
What was his first name, doctor?
So that was an illegal use of the word doctor.
Oh, so he's not a doctor.
He's not.
Is he a nurse maybe?
Did he have any medical training?
From our checks, he had started nursing training, but he did not complete.
All right.
So he's also still not a nurse. Yes.
But he had a very large facility in the locality that he was operating in, and even after he was exposed in the media, after a while, when things died down, he went and opened another place. How does that happen? Because I'm certain maybe perhaps there are other people operating in a similar way. How is that possible in this day and age when we have your organization trying to do these checks and balances?
So what may happen sometimes is that as we register health facilities, there are minimum requirements that one must fulfill.
Right.
So what such a person may do is to have a facility registered by a qualified person.
Okay.
But then they end up being the ones
who
kind of employed or run it. And that is why we do the compliance inspections.
Yes.
To go and confirm that the people in there are right. If of any category, they are registered and licensed by the regulators of that profession.
Yes.
And we now keep pulling them out. Like in the very recent inspections we did in Nairobi,
yes,
we actually found over 500 facilities that are not registered.
500?
Yes, small clinics, and especially in the highly populated areas. That tends to happen, and that's why we keep going out.
Okay.
So that if we get them, normally we collaborate with the
police,
security enforcement agencies, so that those people are arrested and they are taken through now the laws as it should be.
So for me to open a medical facility, a clinic, I have to be a doctor. What if I'm an investor? Or what did you mean by you have to be someone registered within the authority?
No, what happens is that currently, because healthcare could be a business,
yes,
and therefore it is not mandatory that for you to open a hospital you must be a doctor. You can be an investor, like you have just said, but then an investor must have a registered company.
Yes.
So basically you must be recognized at the business registration at BRS. Yes.
Okay.
So once you have that, then you identify the location, you set up the facility, and you'll have gotten the minimum requirements in terms of what are the room sizes, what are the other facilities, how will you manage your water and sanitation,
the equipment.
Here there is medical waste, so how will you manage the medical waste? Once you have set that up, the county public health department in the county that your facility is located in assesses the facility for suitability as a health institution. If they give it a go ahead, they will have looked at all those things we have mentioned, the infrastructure, the ventilation, the water, sanitation, how do you go about waste management and all that, and the other now county licenses.
Yes.
If they give it a clean bill, they now recommend that facility can actually be used as a hospital.
Okay.
Now, as part of your application to the KMPDC, that's one of the documents that you will provide.
From the county?
From the county.
Okay.
Yes, so that so you'll have your business registration license, your NEMA licenses, or waste management agreements with the providers, the county public health inspection report, IDs of directors and such things. So that is what you present to us. One of the other very critical things that you present to us is who will be in charge of services at your facility. Now that is where the medical part of it comes. So the investor who is not a doctor now must show us. For example, come with Dr. Kariuki and say, Dr. Kariuki is in charge of health services. So even when there will be complaints by patients, we will not look for the investor. We will look for that person because they are the ones responsible for patient care.
Okay.
The investor has only provided resources. They don't know how to treat patients. But it is that person who is in charge. So the person you bring us may also just determine the level of service we are going to allow you. So if you come and say, I have a nurse or clinical officer that will be in charge, then the highest you will get is a level 3. Because that's the highest they are able to provide in terms of the skills they have. Except those who may have specialized in one or two other areas.
He could be or she could be the director of medical services in that hospital.
Yes.
But then, under him maybe I have an oncologist, or that's not possible.
And highly unlikely. Highly unlikely. We want the person to be in charge.
To have an understanding.
Yes, because the person in charge is also somebody who can make medical, clinical decisions. So they are also being referred to. I'm having this challenge. What do we do? So you see, the oncologist now, where will they? So the nurse, can be there, or a clinic officer can be there as an administrator. And they are the administrator, maybe even the chief executive of the facility. But they are not the medical person in charge. The medical person in charge is somebody with the highest responsibility. So if you come with a medical officer as your person in charge, we cannot give you anything beyond a level 4. Because the medical officer can make level 4 decisions in terms of care for the patient.
So these private hospitals that we see around, and even maybe the level 6 ones, the private ones, the person in charge of what you're talking about is usually like what level?
Is a medical specialist. Is a recognized specialist in the country.
So it could be an orthopedic surgeon, it could be a neurosurgeon.
Because out of all the tens of specialists we have, there's one who is who will be in charge. But they are a specialist. Because you can't be a specialist in everything, but you understand all specialties. And you understand what may need to be done. So when you are told there is a certain problem in the facility, you can quickly make
a decision
about
Is that why when you go to see a specialist, there's a point where they tell you, actually, I need to refer you to somebody else. Meaning they understand the problem, but they also understand that somebody else who's actually trained to deal into that particular area,
who can give you now the best care for what you are having. So that's how it goes. So so all of them, whether, as you've said, even the private hospitals, even like at even public at Kenyatta National Referral, there's a director of clinical services, and that's the person we target when there are complaints about how patients were taken care of.
I get it.
But there is also a chief executive officer who may be or may not be a doctor. But there must be a director for clinical services.
I have to ask, what then do you require as a qualification for somebody who's going to be a CEO of a medical facility?
We may not have set standards for that.
Why not?
Because sometimes the chief executive officer position is relatively new in the medical practice in Kenya, but previously it was expected that there would be a doctor. But I think with the changes in advancement and complexities of hospitals, it's largely somebody with management skills to be able to manage a complex facility like a hospital is.
What I experienced in an earlier time was not a CEO, there was a hospital secretary.
Yes.
That person was like the administrative head.
Yes.
Of that particular hospital.
Right.
And you're right when you say, and you don't need to be a medical doctor to understand the administrative aspect of a hospital, but surely don't you need some knowledge about this institution that you're managing?
Right. Yeah, you need. And glad that you've mentioned the hospital secretaries, because reforms were undertaken, and now it was said you must be a medical doctor, and they brought in what was called now a medical superintendent. And the medical superintendent was made actually now the administrative head, both for clinical and administrative. And then now the hospital secretary was renamed to hospital administrator, who would now manage the non-medical parts of the hospital, like maintaining infrastructure, building maintenance, making sure the hospital is clean and all that. Whereas now the medical superintendent was now above. So there was an administrator and a clinical director in most facilities. That's what you'll find now.
It's interesting.
And now the medical superintendent was now the equivalent of a chief executive now. So they have the medical background and also have administrative
duties,
capabilities.
Okay.
And we have even included in our core curriculum that skills in management, entrepreneurship are part of the training of doctors.
So are we saying that if we look at, say, these sub-county hospitals, who will have a medical superintendent, that they also all have to or must have a hospital administrator?
Yes, that's what we are saying. So where there is a medical superintendent, there will also be a hospital administrator. Yeah.
How do you guarantee that all these hospitals have that particular complement of individuals? I'm saying this because I've seen hospitals where you have the med sup, as we call them, but the hospital administrator, the med sup ends up doing the administrative functions of that particular hospital.
Yes, they are there. I think some of the facilities are unique, especially county facilities, and counties make their own, administrative decisions. But I know that at the beginning of devolution, there was guidance, a guideline to all the counties in terms of how they can structure their administrative functions within the facilities. Yes, the medical superintendent, being the person authorized, still takes overall responsibilities, including what the administrator does. They have overall responsibility, but the administrator is there for the day-to-day management of those aspects.
So for purposes of that particular health unit,
yes,
he is the account holder.
He's the accounting officer. Yes, so they take responsibility for it. Yeah.
Right. So,
yes.
Daktari, what's the relationship between KMPDC and the Rural and Urban Private Hospitals Association of Kenya, RUFA?
I think there is no direct relationship, but KMPDC works with the stakeholders within the health sector. And stakeholders are all the people that either are involved in providing health services, and the people providing services are the doctors themselves, the dentists, the oral health officers, and the hospitals. Our other stakeholders would be, the government, in terms of that it provides the laws and the policies. We know that private providers, now when we talk about hospitals, sometimes they have groups where they form associations, and these are very critical to our service delivery and ensuring that public trust continues being there. And we have actually gone to the extent that in our council, which is in other places called a board, representation includes a representative of healthcare providers.
Okay.
And the various groupings of providers include what you have just mentioned, the Rural Urban Private Hospitals Association. We have the Kenya Health Federation, the Kenya Association of Private Hospitals, the Christian Health Association of Kenya, you know, with faith-based.
So there are quite many.
The SUPKEM, you know, for the Muslim hospitals.
Right.
The Kenya Catholic Conference of Bishop for the.
Wait, are you saying that all these are represented in?
No, not all of them. Now, one of them at every given time, is
okay
on the council.
The reason I'm asking that is because we've gotten a question here asking. Let me find that out. So private hospitals threaten legal action over unfair facility downgrades. What was this all about? You know, I think some people may have gotten concerns from the inspections that we do. And because we deal with individual hospitals when it comes to compliance, not with groupings. Yes.
Even when we deal with the public hospitals, we deal with individual facilities and not their owners, let's say the county. Because if a mistake has happened at Mama Lucy, it's not about Nairobi County.
It's about Mama Lucy.
It's Mama Lucy. So we deal with Mama Lucy. So even when we undertake those other inspections, whereas a facility may be a member of an association, it's about the facility.
Okay.
And the good thing about our work and our compliance inspection is that it is more supportive and how safe that facility is to continue providing services. So for example, a facility that we had registered at level 3 and we go and find it no longer is operating in its theater because it does not have employees in theater, then there is no need of telling the public that this is still a level 3. It is now a level 2.
Okay.
So even as you go as a Kenyan, just know here you are going to get basic care.
Okay.
Yes, but if we continue allowing them to market themselves as a level 3, then we shall be lying to Kenyans.
Yes.
Sometimes we even in a level 4 facility, we can go and close part of the hospital because it is no longer providing
those services.
Okay. So sometimes even when we close or downgrade, it could be part and not the whole.
Okay.
Yes.
I'd like to understand the communication that you have within health facilities with regards to one at the time when they are given their licensure to operate.
Yes.
Now, the process of ensuring that the standards that they are licensed for are maintained, there is that process.
Yes.
And then the inspections. And then lastly, when something isn't quite what it should be, the process that KMPDC takes to remedy the situation, including, of course, or rather, not excluding shutting down certain parts of the facility or the facility. Can you walk us through this process?
Yeah, so what happens is that once a facility starts operating, they are already aware that there will be regular checks.
They are told.
Yes,
it is documented.
It is documented. Even in the law, we have even regulations, licensing and inspection rules that is available to them on the website, on the law reform website. So they are aware that those regular checks will be done. So when we go for a check, we can go for what I said earlier. We can come in unannounced, and we can also come in announced on schedule. You know, when like we go on schedule is because probably we will do a very detailed inspection where we may even want to look at your employee files. We may even want to go into all your contracts and see how they are. But when we come and announce, we also know you may not have kept those things just where we will pick them.
Yes.
Maybe the holder is away on leave and all that. So when we come in and announce, is basically the service you are providing on that day and how it looks like. So once we arrive there, we will go in and introduce ourselves, because not everyone who walks in is from KMPDC. You may have unscrupulous people claiming to be, right? So we now announce ourselves, identify ourselves, and say what has brought us. We do the whole walk through the facility with you are representative as the facility owner or the facility in charge. And where we see mistakes, it's not something we are going to come and tell you we saw.
Yes.
We are seeing together. And you also accept it is either the standard or not the standard. In fact, as we walk through, we might even pick best practices to tell other people, by the way, go and see what Hospital X is doing. If you can get there, it will be good for you too. So we walk through. At the end of it, we actually have a sit down, like a feedback meeting, an exit meeting, where we agree that these are the very critical issues that we have seen. Some are minor, some are major. If all are minor, we just give a recommendation. Please check on this. We will back in 3 months to confirm that you have worked on it. There is no closure. There is no sanction at all. It's just recommendations to improve maybe 1 or 2 gaps.
So by the time you're closing or shutting down a facility,
they know. Yes, they know.
Okay.
Yes. So we then move now. If it is major, we can tell you actually for this, we don't think we can even allow another patient to walk in for this service. So we are closing. Now. Courts, they also need to get updated. So it is usually the responsibility of the facility to inform us that they have updated their bed capacity. And we go and confirm and verify that it is true, and we update our records as such. Again, every year, at the time of renewal of the annual licenses, because for one to operate they require an annual license. In fact, we are opening the next renewal period maybe from tomorrow up to the end of the month and the year, for those who will be very late. We also still again give them an opportunity as part of the renewal to give us their, what we would call a biodata for the facility that would include infrastructure like the beds. Yes, and we give them an opportunity to do that. Once we get that, we update. So upon request, it's usually nearly immediate, but we do verify. So remember, recently under the Social Health Authority, to continue ensuring patient dignity, the ministry and the Social Health Authority indicated that and implemented what they call a 1 patient, 1 bed rule. And that's why it became very important for all facilities that had not updated their records to update their records with us. Because what is happening is that our system, being an online system, is connected through some interface with the system at the Digital Health Authority and the Social Health Authority. And changes we make in our system are visible to the Social Health Authority within minutes. Yes.
So if I had a hospital that had 30 beds, if I add even 5, I need to...
You need to tell us, as long as you'll use that to claim. Because if then you claim for 40 patients and you have 35 beds, it starts looking like these 5.
It makes sense.
Yes. So that's what's happening. And we've done for very many hospitals that have requested for us to adjust their capacities.
Hospitals, health facilities have boards. How do you determine who gets to be on this board and what function, what is their role, what do they do?
Are we talking about public or private hospitals? Or both?
I am referring to hospitals in general. Yes, because they all have boards.
We do not dictate on who should sit, but what we say is that every facility should have at least a clear management structure. A management structure meaning there is a board, and then the day-to-day level of management, just like we see for, let's say, for government, we expect that they follow what is called the Mwongozo code that has a membership of 9, and then there is another level of the day-to-day managers who have separate functions. That the board is more a policy making organ to drive the agenda of the facility, ensuring that they continue providing quality care to the people that they serve, whereas we have now the management level that is there on a day-to-day basis providing services to to the clients who visit the facility. We know that the county facilities also have their own management structures with boards and the same two-tier level of governance.
How do you involve the community in these boards? Let's say, for instance, if you look at the levels of hospitals, level 4, level 3 hospitals are the hospitals that you're most likely, or for health facility, you're most likely to find right across the county. How do locals get involved in the management of these facilities? I'm now referring to public facilities.
Yes. The guidance that had been provided at the time of devolution was that community members contribute at the dispensary and health center levels. Actually, it was the community that was electing what were called facility committees. They were not called boards. The facility would, the only thing they would be told are, you'll have X number, I think it was 5, but I need to go back and check the details on that. But that number was actually elected by the community members. They hold a baraza, those who live around, and choose from among them a number of people. And one of those chosen is then now appointed as the chair of that facility committee. But in the hospitals, what are the sub-county hospitals now? The county would appoint the membership because now it may be a facility that is covering several wards or villages. So they would now make sure that the whole area is represented, but they must also make sure there is community representation from among the people that they choose.
There is a viewer here, anaitwa where is that? Okay, I think he's called, or she's called Star Kenya. And he says that has the gentleman, that is now you, admitted that the state stroke quality of healthcare in Kenya is horrible, just as a fundamental starting point of discussion, then he builds from there. Okay, that's a very harsh assessment, but what do you make of it nonetheless?
Probably maybe what he may need to know is that in Kenya, we see about 3 million visits in a year. Maybe if you divide by the number of days, across
all health facilities.
Yes. And I think now the numbers are higher as information and data is being collected through the social health authority, system where you have to report every visit.
Yes.
So, but previously, the recorded number of visits were between 2 to 3 million outpatient visits per year.
This is both local and foreign visitors.
Yes.
Okay.
Anyone who visited a facility in the country and that facility recorded into the what is called the National Digital Health Information System, DHIS. From there, KMPDC in a year has been receiving an average of 100 plus or minus complaints in a year. So even if we say there are a few others that were not recorded, they probably may not run into thousands.
Okay.
So when you compare that with the 3 million visits, that tells you that the quality that was provided was good enough that many people were happy with what they received. Yes, so I think it is not right to say that we don't provide quality care. Yes.
I think it was suggested a few weeks ago that we would have now some kind of rating system similar to what we have for not hospitals, but for the hospitality industry, where we can actually rate a certain hotel as a 5-star because of maybe the kinds of services I received there. I found they were very clean, very polite staff, and so on and so forth. What do you think of that suggestion, and is it something that can actually help advance our healthcare?
Yes, I think the ministry already has developed a quality framework that actually includes what you have just mentioned. It's just the implementation that has not taken place.
Okay.
And I think that's one of the things that is probably in the pipeline to be done, including even maybe by us. Yes.
Won't that then put some hospitals in bad light, because maybe they actually do have good services, but just because I had a very bad experience for whatever reason, then I go there and rate, say, Pumwani as a 1 star because nipata huko watu wananiongelesha vibaya.
Yes, I think what will happen now I think it requires to be very objective. So there will be many aspects of the rating, where the personal rating will be one aspect of the overall rating. There probably will be other ratings that will other parameters that will also be used before we give the overall rating for that facility.
You know, when you talk about the hospitality industry and you look at what it is that they consider, okay, they're not very different from the hospital in the sense that they, first of all, you ask the service they provide. What do they provide? What level of service? Whether it is accommodation, whether it is the food, whether it is the facilities. Do they have gym? How many gyms?
Customer care,
swimming pool. Do they have specialist restaurants and so forth? Now, in a hospital, let me just state my position. This is a very sensitive area, and unless the details that we are saying will be looked into before this rating is actually put in place, it could cause more harm than good.
This rating system?
Yes, it could cause more harm than good, because the moment you have a rating system, essentially you're saying that you've introduced a commercial element into this particular industry, whether it's in a public service or not, where on the one hand, if you're to be positive, you will be challenging those who work there to maintain those high standards. But this country is called Kenya, and systems of that nature are subject to abuse, because there'll be human beings at the end of it who who determine those ratings. Okay? Now, if you're saying that the ratings have a huge component of customer care, where your opinion and your views as the receiver of the service also have a big say, it would help tremendously. But the problem is this. If, as it is, KMPDC ensure within the resources that they have and the limitation they have, that hospitals actually do what they're supposed to do and perform. Private hospitals already compete in providing the sort of services because it's a business. They compete without this system being in place. Because if they know that if anything goes wrong and word of mouth spreads, that business is going to shut down. They do not need KMPDC to shut it down. Where we have a problem is in the public sector. And the public sector, it isn't that we do not have sufficient health practitioners to work in there. It's resources. It's usually resources. People want to work, but they do not have the resources to make it work. So this system, much as
the rating system now.
Yes, in theory, it sounds like it would be good. In practice, it may cause us more problems than it may provide solutions.
And I'm actually inclined to agree with CT, because if I know Hospital X, if I go to ratings, because again, a lot of our information right now we get it online. So I want to go, get treated for disease W, and then I check out and I see, hey, hii hospital iko hapa karibu na mimi, people don't like it a lot. And perhaps a lot of other patients and potential patients might actually do something similar and check it out, and then you will find that that particular hospital is not getting business because no one is going there. Because if I look at the online rating, people are saying there we have rude staff. They're not even well equipped. They don't even treat people better. And that is actually killing someone else's business, and especially if it's a private hospital.
And that's true, because and that's why we were saying that we need to look at very many parameters. And the most important thing is actually whether the facility maintains what we call the minimum standards expected for providing a certain standard of care. If they can do that, then it doesn't matter whether they are A, B, C in terms of rating. And that's why you look even when it comes to the doctors, we don't tell you there is a best doctor. We just tell you they are doctors. They have met minimum requirements to provide services at that level. So that's why even in the degrees in medicine, we don't give distinctions and passes. Everyone just passes.
So there's no first class.
Yes, there's no first class, second,
a pass or a fail.
No. Yes, it's either you have passed or failed.
Right.
Yes, yeah. So because we don't want to bring that notion that because it would be commercialized, as City has said, that if I keep saying, and in fact that's why we even have advertising rules. We have the medical advertising rules from 2016, where one should not claim that they do better than the other.
Yeah.
So a hospital cannot say we are better than the other hospital. You can only advertise the services you provide, but you cannot say they are the best.
Yeah, because we now see some hospitals saying that now we have a cardiology department. Now we have a PET scan or a CT scan.
Yes, that's So that service is there, but you cannot say it's the best. Yeah, because it's relative.
But actually, if we're being honest, there are people who the public perception of services. There are people who will say Hospital X is the best in cardiology. Hospital Y is the best in oncology. Ukiwa na enda tu pale. Ukiwa na shida ya urology, enda pale. It is public knowledge.
So, yes, now that is the hospital that is selling it.
Before you say it, I want to correct this gentleman. It is not public knowledge, it's public perception.
Perception. Yes, I wanted to say it's perception.
Now continue, please. Yes.
It's actually a perception by the public that in that place maybe they get better service, they get the way they are received and all that, because there are very many aspects to service delivery. This is actually a service provision, like a hospitality service.
Yes.
It's just that there's that technical part of it, which is medical, healthcare and such. Yes. So
because we even have celebrity doctors. Well, they won't carry themselves as celebrity doctors, but everyone knows the doctor is so and so. Because he works probably in a certain hospital treating a certain ailment. So people will always be like, problem yako ni bones. Enda kwa Daktari Kariuki anakuanga hospitali Y.
Yep. And it's the way people have perceived and the way maybe the provider has also presented themselves.
Yes. Interesting.
Or when you're talking of perception, if it is known that certain specialists treat certain high-ranking officials or publicly known officials, then it is assumed that person must be very good at what they do, and that is, and yet for the longest time, our doctors are all trained in the same institutions.
Yes,
right.
So it's not as though somebody gets better training elsewhere. They are all, the majority are trained there. But Paul, there's something that I like just to mention.
Right.
We with regards to public perception, public hospitals get a bad rap. Okay, when I talk about resources, I'm going down memory lane. This is the beauty of having lived long. I know over time when all you did was go to hospital. That's it. You get checked, you get treated, you get drugs.
Done.
Yes, done. We were much fewer then. The public hospitals that people give a bad rap, these public hospitals probably have the best trained people you can actually come across.
Yep.
Because to work in a public hospital, you actually do need to be qualified. You just can't work because somebody says this. Now, the unfortunate thing is that most people don't know this. Because resources are sometimes limited, people prefer private hospitals because they feel they will get the resources they need. And yet the expertise, it's not that one hospital has better expertise than the other. No. It is resources that is a problem. Yes.
And actually, people in cities generation, and especially because I'm referring to him because I know this about my parents as well. They will always talk about going to a public hospital because, number one, then they come from that era where Kenyatta Hospital, for example, was one of the best.
It still is. Yes. That's the point. It still is.
Public perception.
Yes.
So you will find them saying, I need to go to the orthopedic surgeon, for example, in Kenyatta. I need to find the cardiologist in Kenyatta. Because we also know that some of these doctors anyway, you will find them in the morning at Kenyatta and probably in the afternoon you'll find them at another private hospital. You
will also find that some of them also teach at the medical school.
Exactly.
Yes.
So I agree with you in terms of at the end of the day, these experts anyway are the same and actually qualified, very much qualified to treat whatever it is that we are suffering from. There's someone here. Who is this? Sonet is saying similar complaints are also said of hospitals in the United States. Deplorable, expensive, terrible customer service, etc. I think he or she is alluding to the this whole issue of rating. So if we were to rate, I believe we'd see tutaona maajabu kwa hii rating system.
Right.
How do we
hospitals improving is something we call continuous quality improvement, because even the quality that you have today may be good, but tomorrow it may not be good. So it's something they have to keep doing continuously.
Yeah.
That is why they have something they call continuous medical education, so that you're constantly updating your store of knowledge, so that you actually understand what is current, what is being looked at, and even the changes in policy that have come about as a result of what it is that you do.
But then actually, what is the retirement age for a doctor?
There is no set. In fact, it's a worldwide discussion that one can practice for as long as they are fit to practice. But maybe at some age, it's a discussion worldwide that maybe after a certain age, let's say 75, 80, one can have annual confirmation and contracts that they are still fit, and to self-report when they need to now retire from active service. Because sometimes what happens, the movement from one may be just that for a surgeon, maybe they are no longer able to operate, but it's not that they are no longer able to teach. At least they can teach and give the knowledge.
But
it's just the operations that they may not be able to take you through. They can go to you with you to a theater and tell you, now do this,
and instruct.
do this, instruct. So you see, they can move from that active to less active and finally exit completely. And we allow them, we allow that choice. Even here, doctors write to us and say, from next year, I will not renew my license. I've stopped active clinical practice. You know, such.
But do we have a structure that actually accommodates what you've just said, where somebody decides they are not going into active practice, but they probably want to teach? Do we have such a structure that
it's not in the law yet, but it's actually something that is work in progress currently, where we can even allow even other doctors to report the other doctor that he still thinks or she thinks he should be active, but we as fellow peers think that you now actually should actively step in and stop them from continuing practice. But that's now work in progress that we shall be able to have it in writing in a short while.
You know, I asked the question. There is a fundamentally human resource question that is often asked about that very subject of human resource and how it is managed. When somebody has been a doctor for at the age of 75, what that person knows, it's a treasure trove of knowledge. And in the absence of a structure, it just filters away and it goes away.
Right.
The US is often given as an example, and rightfully so in this respect. If you look at, for instance, the way they handle their politicians, when somebody retires, you then enter what they call the lecture circuit. Because now you talk about practical things that you know. Because even before you become a politician, there's a subject that you had studied. I have witnessed this firsthand, even in research, that some of the people who had institutes within universities, research institutes, are very elderly people. Some are even in their 80s. Okay? But that then guarantees that you are constantly renewing the resource base, because all that knowledge is actually literally being passed on to other people. They will not practice, but they are within the institution, and that knowledge is of great benefit to that institution. Because that continuity that we speak of is maintained. There's a policy that guides it. It doesn't go away. And then you look at even the way they structure, for instance, in a university setting, how it is people become professors, tenured professors, and what have you. There is a lot that has to do with the people whom you have mentored and nurtured, and what it is they have become. Not just you've written, I've mentored so and so. The eventual outcome of your work has to be seen. So you find this is a country that doesn't really lack for expertise at any given point in time, because the knowledge is not only guarded, but it is more or less stored and is passed on from one generation to the other. Right. That is really my question.
Yes.
will we have a structure that actually does that? Because forget even town. Say somebody retires and goes home. They're 75. They go to their Gishagi. That is still a resource that could be used now that something like health is devolved. Can you imagine just how useful that person would be in the village?
True. Yeah, and I think that's something that we need to do even now beyond medicine to even other sectors.
Yes.
Have a structured way of ensuring that especially those skills are passed on to the other generations that are following. Because it's only that maybe active life has been reduced to a certain extent, but it's not that the cognition and such has gone. So as long as they are still available, we can continue tapping into their skills and expertise and the things they have learned over the years. And we are actually learning from other countries how they have done it. We've seen some countries that usually allow, like City has said, for one to sit like in a teaching school, maybe even with some base pay, but with no real, that performance contract thing that you must operate 100 this year. But but they at least told at the end of the year, show us how many other people you have passed your skills to. So they probably will take one or two people or three and mentor them. And now at the end, it is also checked on, is it true? So the person you have mentored probably is allowed to, let's use surgery because that's where it may be more practical. How this person can operate independently from what you taught them. So another surgeon comes to watch. A surgeon who is nearly of the skill of the mentor comes and watches and says, yes, that skill could only have been passed from such expertise. And you're allowed to continue the next year and the next year until now you say, now allow me to take a rest. And so
so there's a Sugut Kipletinius who's saying, make an order. Now this is you. Make an order that all public health centers and dispensaries be given bed capacity in the system, at least 3 beds for dispensaries and 5 for a health center, and be done within this week. Huyu ni mwananchi ambaye anapeana amri. But first of all, what he's talking about, is this something that is within your mandate?
Yes, it is, and but it's a sector thing, and it's good he has asked that question because we actually raised it with the Ministry of Health. By nature, by law, level 2 facilities have not been recognized as inpatient. Remember, even earlier we said that level 2 is a dispensary. Minor ailments only provides outpatient services. But we do realize that sometimes, especially in rural areas, especially ladies giving birth may go in what we call advanced labor, and within an hour of arrival into a dispensary they deliver. Now that facility is not able to recoup for what it has used if it were to be paid, for example, by any insurer, because they are not recognized as an inpatient facility, whether SHA or any other insurance. And now we have agreed that we are going to allow those, and I don't know, maybe he has already heard that we are going to allow 3 beds. But now for us to allow that,
maybe he owns a dispensary.
Maybe he does. So, but for us to do that, they have to make a request. So they make a formal request, and then we are going to be able to do that for them. We are doing that. For public facilities, we are requiring maybe a letter from the County Executive Committee for Health with a list of their dispensaries. We just allocate that. For private, they now make their direct request, and we also do the same. So it's something that we do nearly immediately or soonest after we receive the request. So it's something we are doing. And remember, for us, it's an issue of that Kenyans continue accessing care from the closest place where they are.
Daktari, once upon a time, the only people who we knew could run health facilities were medical doctors. What was the thinking that then allowed the entity that you now head to allow nurses and clinical officers to also open up and be licensed to run health facilities? What was the thinking?
Is that the population increasing, and the scope of service that is required. When you look at, let's say, a dispensary, the scope of service is for very basic minor care, and that scope is at the level which even a nurse or a clinic officer undertakes even in their training. They are able to identify and make recommendations on certain illnesses, and also determine who needs to go to the higher level. And so that was the thinking behind it, that maybe for a level 2 clinic, level 3, some of the level 3 outpatient services, the scope that is expected of services there is no harm to patients if that category of health professional is allowed to provide the service as the highest available skill, and to be able to reach a wider population across the country. We have a population of 50 million Kenyans. Currently our register is of 17,000 doctors. That tells you that we have a large part of the country that is not covered, but those people still require services.
Yes.
And so by allowing that the basic scope, at least somebody who can identify and refer where as necessary, is good for the country in terms of ensuring that at least the whole public has access to basic health services.
Right.
So what we just usually emphasize is that no one goes beyond their scope, because once you go beyond your scope, it can lead to complications or delay in managing and getting into complications. Right. Yeah.
There's some fairly remote places in this country.
Yeah.
Some you even need to access by a boat, and they have health facilities.
Yeah.
How do we guarantee that even such places get inspected?
We have done it. We actually cross with boats to the areas in Nyanza, in Lamu. That we may do like maybe once every 2 years, but we actually get to see those facilities.
I say this because I once upon a time came across somebody who I had worked with, and who was he was actually what we call a community health worker in those days. The fellow had opened a clinic, and he had 2 drugs that he offered his patients, Panadol and Actol. So it was reported and he seized, but there was a very large number of people who were lining up to see this particular person. This person had 0 medical training, 0. But found him with a lab coat and
stethoscope.
Of course, he had a stethoscope. Stethoscope says everything. Lab coat, stethoscope.
You inafanya kuwa daktari.
Yes, you see, if you have a lab coat and you walk in the street, you could be selling smokies. So you will not qualify as a doctor. But if you're in a facility that's known as a health facility, now there are places that are not just around the corner; they are far. I'm going to give an example, like in Mombasa County, a place called Remba or Ringiti. Those are islands. Fangano is not far. There are health facilities there. Now, health is devolved. So I am assuming that some level of inspection is done by the county team itself. But when a facility is opened, I haven't been there in years, so I don't know. Somebody opens a private facility. What is the ease with which KMPDC would be able to reach that place, see it, and determine whether whatever it is that they're asking for is actually what is at the ground, or it will represent the facility that I told you I once came across on one of those islands, where somebody whom I knew had no medical training at all was running. Yes.
Yeah, and that's why, if you remember at the beginning when we said about the minimum requirements, we work in conjunction with the county governments, and that now would help us address some of the areas that we may not reach, because for the county Public Health Inspectorate Department to provide a report about the suitability of a place to be used as a facility. They usually will have gone and seen physically and assessed the whole place and even checked who are the workers that are proposed to be in that place for that time. So we use that as the initial requirement that a facility exists. So after we allow them to start, then we now follow with an inspection by KMPDC to go and confirm the actual situation on the ground. Yes, we do agree that maybe because of the limitation of available resources, some may slip through, but once we get to have that, we take actions immediately once it gets to our attention. Right, yeah.
How can one report actually some of these rogue practices, rogue institutions, rogue or even quack doctors? How do we get to you?
Yes, over time now we have improved from having to be reported manually or by writing. Now you can get to us through email, through telephone. You can call us on 0727 666 444. We made it simple. Email through our website, and for immediate knowledge, we actually now have a toll-free SMS where you can text a facility name or even a doctor's name, and it will tell you that that's a registered facility, it's a registered doctor, it has a current license.
Okay.
A text to 20547 is toll-free. So we
just
have
repeat that again slowly so that people actually get to hear it.
Yes. Yeah, to get to confirm whether a doctor is licensed or not, you send a text to 20547. On the text, if it is a practitioner, you start with with the letter P, then hash, then the name of the doctor, or their registration number if you know it.
So it could be P hash Mungalambuvi.
Yes.
Okay.
Yes. You send that to 20547. Within a minute, it returns a message saying that person is in the register, they are licensed or not licensed.
Okay.
If it's a health facility, then you instead of P, use H. But the others is H hash, name of the facility, and then send.
All right. So it's H hash radio generation.
Right.
Itaniambia kama hii ni hospitali halali.
Yes.
Okay.
Yeah, kama sasa ukiandika hiyo ita return kitu ikuambie not found in the system.
For sure, because
so meaning it is
not a hospital.
Yes.
There is this question of the curricula for medics. Is it something that you align with not hospitals but universities to ensure that what is being taught in our facilities in Kenya is actually in line with industry practices?
Yes. What we do, what we develop is what is called a core curriculum. The things that must be taught by any university that is training medicine or dentistry in the country. So from the core curriculum now, the university develops is now, it customizes because they may have a few common courses that they want to add, maybe a few other things that they want to add, whether they are, let's say, attachments and all that. But the core is what has been developed from the council. So, and even by the time the Commission on University Education approves that curriculum, it will also have sought our comments on whether that curriculum from that medical school is fit. So what we will do is to check whether it corroborates or is in compliance with our core curriculum, so that what is trained is the expected core competencies of the practitioner that will be the product of that curriculum training. Yes.
Do all the dentists and medical doctors study anatomy?
Yes, it's the first training.
Even dentists.
Even dentists.
Yes,
They do.
the first 2 years.
Yeah.
Hata leto tu jobon jueni dentist.
Hapana. What they do, because it's part of the body.
Yes,
so
yes.
They will know the whole body, but they will have a lot of detail around the head and neck. Yeah, because all these places are interconnected. Okay. So the dentists also do anatomy.
Yes.
But they do more dental anatomy than rest of the body.
Yeah.
Whereas now the doctors will also do the whole body.
Yes.
Not when it comes to let's say to the teeth and mouth, not into the detail that the dentist will go into for dental purposes. But actually they use the same anatomy classes.
Yes.
What about the pharmacists? Where do they fit in? Because these are people who are prescribing all manner of things for this same anatomy, this same human being.
Yes, now where the intersection is in something we call physiology, medical physiology, you know, the way the body functions, the way it will metabolize or metabolize as in how it will digest the medicine and excrete them at the end. That is where the pharmacists come in.
So do they do anatomy though?
No.
Okay.
Yes, and so that's why we say in terms of the scope, the pharmacists will not be the one to make a diagnosis that this is the disease and all that. They will only come in at the point of the medications required and how to manage any complications of the medication. But we do know there are those who do something called clinical pharmacy. But I know City is laughing because you walk into a chemist and you say my headache and all that. So which is that's a level 1 treatment generally. It's like at home.
Actually, now that you mentioned now that you mentioned clinical pharmacy, do clinical pharmacists do anatomy?
No.
They don't.
They still do pharmacy at a higher level where they can tell us more about, if I give you 3 or 4 different medicines, how those medicines may interact and affect one over the other. So is there one that will probably, because of the way it is metabolized, the doctor may require to reduce the dose, or increase the other, because if these two are together, this one makes the body metabolize it faster. So in terms of changing those dosages and such, but not in terms of the clinical improvement of the patient, in terms of their disease and that. They only come in terms of maybe how drugs will interact and which is the best for which condition, which are the best combinations for a certain condition.
Do they carry the title doctor?
In Kenya they do, in the rest of the world they don't. Yes.
What do pharmacologists do then?
Now pharmacologists now deal with the actual medicines, and they can be able to tell you what is the half-life, like if one takes a medicine, how long will it be in your body, how long will it take to get to the level that you can get treated, that will be useful for the body.
Is it a discipline or is it a specialty?
It is part of the larger pharmacy practice. So pharmacology is one of the subsets of pharmacy practice.
There's also another one called pharmacognosy.
All those, yes. So they are all part of the larger pharmacy. So a pharmacist can decide to specialize in pharmacology. Even doctors, actually, there are those who do something called medical pharmacology at master's level. And you'll find those mostly are what we call physicians, internal medicine specialists, because they get a lot into how drugs interact, which, how levels, how they get metabolized and all those things.
Why I've been smiling throughout is because when you talk about pharmacists and you talk about a co-curriculum, I'm going to ask what the content of this co-curriculum, but I'm thinking, should pharmacists not also do a bit of anatomy? The reason why I'm asking this question, since we're discussing, this is a theoretical discussion. Here you are prescribing medicine and you've said the interaction at physiology, and you said the physiology. Study physiology. There are cadavers that exist in medical school, which are there for all sorts of reasons. I am certain there will be some who are there because some interaction with some drugs did not quite agree with them, and so they had to go into the afterlife. Okay? Would it not serve a purpose if they actually physically saw? Because when you deal with cadavers, you see it's a body. Okay? And probably that is the time when some people figure, this thing, I'm not going to do this thing. Let me just go and study commerce. It makes more sense.
Economics.
It's easier. Yes. When we look at, this is my question, when we look at our curriculum and you say the key components that you have, the core curriculum, which is really like the bedrock, the foundation on which everything else can be built, how does it ensure that it meets the needs or the changing needs of the population who seek healthcare? That's number one. Case in point, public health. How many units of public health do we teach in our universities to ensure? Because that really, primary healthcare is where most of our ailments are. This is now what research has found. Most people don't need to go to a level 3 or 4 or 5 hospital. At that level of a dispensary, they can be sorted out. Do our curriculums for training doctors actually cater for this? I'm speaking specifically about doctors, not nurses, not clinical officers.
Yes, they do, because the curriculum is about developing core competencies in managing illness, and managing illness starts from prevention. So the public health aspect part of it is where prevention comes in. And even now, internship has even changed. Whereas internship previously was just clinical, hospital-based, now internship includes a section of getting into the community and seeing how things happen at the community level. So the curriculum has also changed in that manner, that it includes aspects of how to prevent disease, how to even do a needs assessment in the community, how to manage an epidemic if it were to come, all those aspects of sanitation, water, hygiene, and all those things are part of the training. And even there is a whole unit where they leave the university and go into what we call a community health program. When you look at the program at Moi University School of Medicine, is actually what City is just saying. That is actually the core. That's the way theirs goes. But now the other core curriculum that we have, so now that becomes the unique part of the training at Moi University. But the core competencies of a doctor as expected are still there. But they do a lot of the community more than maybe those trained in the other universities.
That's my question number one. Question number two. This core curriculum that we have, how much emphasis do we put on continued research? The writing of grants so that you can actually further knowledge in a field that you find of interest, as opposed to only being involved in a research project when you're doing your master's program.
Yeah, I think those are some of the areas that are now, coming up to be included, as that research is a key component of health service delivery and health systems overall improvement. And as City, you say, most of our research has been emphasized at postgraduate level, master's level, but now we are also making it part of the competencies that need to be acquired at undergraduate, basic degree level, to now even stimulate research among the graduates. Now that we are also graduating many, remember there is a time we were graduating only 100 in the country, so those could only be more utilized for clinical service delivery. But now we are doing upwards of 600, and therefore meaning that we can have a percentage that gets into research and such areas.
Okay. As we come to the tail end of this conversation, on the issue of digital information, we are living in the social media age where a lot of information is put out there. How is KMPDC dealing with unethical standards at that level, if at all there are any? Yes.
Yeah. Mostly because we deal with the people we have registered and licensed. We have what we call the medical advertising rules from 2016. Actually, we are in the process of updating them now that social media is also changing very fast and evolving. And reminding all practitioners that our first principle is first do no harm. So any platform that you have is only a platform. It does not remove the responsibility you have as a medical or dental practitioner, that it is your patient first and their safety first. So information as you provide it, provide factual information which is going to be of benefit to mankind with no harm. For the non-medical, we would urge the public themselves to be wary and seek other opinions or other sources of information to corroborate anything they hear on social media, because people are getting into social media calling themselves all forms of either doctors or wellness people or such.
Sana kwa wellness.
And we are actually cautioning the public that as we said earlier, you can confirm from our website if these are real doctors. Those who are calling themselves doctors, is a crime to do so, punishable either by fine or jail. But more importantly, because it's about one's health, to corroborate any information they hear from there with qualified personnel.
Yeah.
Yes.
Okay.
Right.
That's fair enough. Because kwanza our wellness wamefagia watu.
Yes. And we actually in talks and discussions with the communications authority that if we identify any who we believe is providing information that is not accurate, we find ways of how to stop that happening. But it's a very wide area that requires efforts from us practitioners, Kenyans, individual citizens, and media like you to spread the message that let us only go for the right information.
There's one last question which I'll ask in exactly 10 seconds. There's what you call traditional medicine.
Mitishamba.
Yes.
Traditional
medicine. How do you relate to people who claim to practice traditional medicine?
This
they even have clinics.
Yes. We know that the Ministry of Health, this current development of an alternative and traditional medicine bill that will eventually become an act, so that there is now formal recognition of those providers who provide alternative medicine, and some have actually trained in it. And the ministry has previously been providing authorization letters for those who provide alternative medicine, and how now they can get integrated into the conventional, because what we do, ours is called conventional and theirs is the alternative. But remember, even some of the medicines we have actually started from people recognizing there is a certain leaf, root, and the herbs that can, so those are the ones we say may eventually get recognized, so that again they also don't do harm. Because if they do harm, then it ends up on our desks in our hospitals. So if we can be able to work with them, then work through organizations like the Kenya Medical Research Institute, so that we are able to even categorize the remedies that they give. I think we'll be able to work together with them for the benefit of all citizens.
All right. Thank you so much, Dr. for availing yourself for this conversation. I believe it has been of, we've learned a lot. Personally, I've learned so much from this conversation, and in regards to just how our hospitals are operating, and also our practitioners, some of the things they have gone through and what they have done to be where they are today. So we do thank you for that. But this is where we come to an end as far as that conversation is concerned. We're talking about compliance and regulation of the Kenya medical facilities in Kenya. Dr. David Kariuki, the CEO of KMPDC. City, tunasema namna gani?
Asante sana daktari.
Yes.
This has been an extremely informative conversation. Asante.
Yep. And there's still more.
Yes.
There's still a lot more.
Oh, we invite you.
That was the preamble to telling you we are going to invite you again.
Right. Thank you.
Karibu tena na tena.
We appreciate it.